And Mr. Cisneros, you're recognized for 5 minutes.
Thank you all for being here today. Dr. Van Winkle, first, how much funding does the DoD dedicate to suicide prevention research?
So I'd have to take that question for the record to get you an accurate number on that.
Dr. Franklin, could I get that same question? How much does the VA dedicate to suicide prevention research?
Just research, I would have to pull the thread on that as well and get it back. I have the entire budget here with me, but just research I need to pull.
Okay, I'd appreciate that.
Yes, sir.
Thank you. What is the process, Dr. Carlson, or Captain Carlson, you asked, you said there was a handoff. Well, actually, let me go back and ask this question. When an individual is, whether they're coming back from overseas after serving in combat, or they're getting ready to separate from active duty service, what is the process for helping to identify whether or not they're suffering from PTSD or some other mental health issue? Are they self-identifying, or do we actually have a process to figure this out?
Well, both, sir. So the DoD cohort is the most screened cohort of folks in human history. So you will be asked about suicidality, PTSD, depression, and generalized anxiety disorder in a periodic health assessment, in a separation health assessment, and you'll also be asked it every time you go to the primary care doc. So when I just went to Walter Reed, all those questions got asked. So that's one opportunity where you're self-identifying through screening. But it's also DoD policy that there's a warm handoff between clinicians. So you have an obligation as a clinician, including as a deployed clinician, to make sure, because we're all using the same health system, and I have access to the electronic health record as a deployed physician, to do everything that you can to make sure that there's a clinic-to-clinic handoff, if not a provider-to-provider handoff.
So once an individual is separating, and you talked about this warm handoff, when they're getting out, they're no longer seeking or getting DoD military health care, and they're going to the VA. How is that handoff being done from DoD to the VA to making sure that that individual is going to continue to get care? Because one of the things that really does disturb me is a number of those individuals that are killing themselves out of that 20, in 20 per day, are not seeking VA health care. So how are we doing this handoff to make sure those individuals continue to get care?
Well, first of all, we need to meet the patients where they're at. So they need to continue the type of care that they want to continue. A number of my patients who have severe mental illness will continue care at a high level, so psychiatrist to psychiatrist. And that would include a discharge summary, making sure that our formularies are aligned, which they are, between DoD and VHA, making sure the patient has enough meds when he goes to the next place. But the folks who, the predominance of suicide risk in the population is in folks who are less mentally ill. And in fact, we need to meet those patients where they're at, whether that's in credentialed health care or, like my colleague, Mr. Fisher, in confidential health care in vet centers or elsewhere, or in community-based health.
Well, yeah, Dr. Franklin, how do you receive those individuals that need that health care or need that mental health care coming from the DoD?
Certainly. There is a program in the DoD called In Transition, and this is a capability that recognizes when people are on active duty status and they have a known mental health problem, they fall into this program. It's one word, the title of the program, In Transition, and this is a program that then carries them through over to the VA with frequent caring outreach and contact, where they're getting actual phone calls and coached into the VA system above and beyond this process that Captain Colston talked about, which is provider to provider across DoD to VA. There's also this additional safety net, they call it, of this In Transition program. But I think what you're getting at is this other part of the population that ties back to this other question that was asked earlier, which is when we have a known population that doesn't get mental health care over the course of their whole career and or doesn't unpack it, doesn't have a known mental health problem at the time that they leave, they don't fall in transition, they don't fall clinician to clinician, there's no warm handoff because they're not known, then they leave the DoD and then life circumstances happen, unemployment, childbirth, divorce, good and bad that are stressful, and then the challenge is getting them into care at that point, if that makes sense, and I think that's where we could do better. We have work to do in that space, I think.
All right, yeah, one of the worst things I had to do in my military service was to go home, or not go home, but to go to a mother and tell her son that he had committed suicide. I feel for these families that are doing this, and those individuals are going through this, so we need to figure out what the problem is and get to that. So thank you very much. My time's expired.
Thank you, Mr. Cisneros. Mr.